morning, everyone, and welcome back to another episode of Mind Split Cafe. As you can tell, we are Mattless today. He had to take care of a couple things this morning, but we have a phenomenal guest that I am truly excited about. Dr. John, you want to introduce yourself real quick and kind
Yeah,
of go over why you're here today?
absolutely. Right after we clear up the fact that Matt didn't miss because of me.
No. That
Good.
we'll let Matt slide on it, but it wasn't because of Dr. John.
Okay, great. Well, yeah. So my name is John Oberg. I'm a social worker by training. I work in macro social work, so I'm not a clinical social worker, and I work in healthcare. So we work to end type 2 diabetes for patients that struggle with that, with a particular focus on people in low income and rural areas.
Okay. Well, very, very nice to have you on board with us today. I'm super excited. I was able to watch your TEDx the other day, and I just want to start there, if you don't mind. I find that
Sure.
to be huge, and I just want to start off with a couple statistics, key statistics that kind of stood
Yeah.
out. The WHO, World Health Organization, has stated that 6 of the top 10 killers are chronic conditions, as
Yeah.
well as 3 of 5 adults have chronic issues, and 2 of those 5 have one or more chronic issues.
Yeah.
Let's talk a little bit about that. Let's talk on those statistics first because those kind of blew my mind.
I think the other one that I think I mentioned in the talk, I think, was that, there's two types of people: the people that are dealing with chronic disease with them or their loved ones, or people who will in the future deal with chronic disease with them or with their loved ones. Like, we're all going to be impacted. And that's just a part of life in our society. And so it's scary, it's frustrating. And for me, the turning point was when my mother-in-law had a diabetic event that was avoidable, and that's when I got really frustrated and angry and wanted to solve the problem and went back to school to get a doctorate to learn about, like, how do you solve this problem that seems like it should be solved, but it's not. And it's not because people are bad people. It's not because we don't have the right science. We have the right science. We just weren't applying all of it in ways that would work. And so, as you heard in the TED Talk, we did a pilot study. We had 49 out of 50 patients controlled within 12 weeks that had years of uncontrolled diabetes, with great clinical success, dropping their A1C from 9.6 to 6.4. And for people that don't know diabetes that well, you're diabetic when you're a 7. 9.5 is really sick. And so to get that population into control in rural Louisiana in 12 weeks was a real victory.
Yeah, no
So
joke. That's phenomenal, and I kind of like the way you had mentioned it. I wrote it down because I really like the way what you said. But so on the pilot study,
yeah.
can you give us a little more information as to because you said, and this is what I wanted to go back. Sorry, my brain's all over the place because this is just there's so much to unpack with you. So, in your TEDx, I did hear that you mentioned we kind of have we have the know-how already. We already have the technology. It's just not being utilized properly or in the fashion to get this going. Can you talk a little bit about that as well?
I think the people that develop technology for type 2 diabetes and the people that develop medicines, I mean, that's just an amazing amount of great work that's being done and been done. And so super grateful for all the work we continue to do. And I hope we continue to invest in that with the size of the problem that it is. And in addition to that, we have what we need to help people today and move forward to solve type 2 diabetes. And I think we showed that in our pilot study, and we're showing that in our clinic today. We have a clinic that serves patients in Texas and California, via telemedicine. And, that includes everything from, finger sticks and taking blood to constant glucose monitors. We have all the different types of medicines that are being used to help patients. But it goes beyond that. I think we have to help patients make the changes they want to make. And so there's lots of people that want to make changes in their life, but they aren't making the changes they want to make. And so the question I wanted to answer was, why is that? And so we went and we started to answer, like, why do people, know what they want to do? They know how to do it, but they don't do it. And so that's what we help people to do, is kind of set up all of the right circumstances so that people are more likely to be able to make and sustain the changes they want to make. And
Yeah,
that's where we started.
absolutely. And you know, for some of the listeners out there, a LCSW or social worker is a licensed social clinical social worker.
Mhm.
Now, for a lot of people, LCSW, when they think of that, they think of mental health, or they think of even substance abuse. Can you kind of dig into how an LCSW plays a role into this as well?
Yeah, sure. So, we use clinical social workers to come in and assess a part of the patient. And what I mean by that is that when we take a patient into our practice, we first assess all of the medical conditions alongside of all of the mental health conditions that may be impacting those medical conditions. And so some of those mental health conditions are caused by the medical conditions, meaning that, like, if I have chronic type 2 diabetes and I have anxiety because of that, that's one thing. If I have anxiety because of my work, that's a different thing. Or, there's a whole lot of reasons that people can have anxiety, obviously, but knowing the cause of that anxiety, to understand whether or not it is caused by the disease, is important in how we choose to intervene, right? So we
Yeah.
look at the medical conditions, we look at the mental health conditions, and we understand whether they're caused by medical conditions or caused by other things. And then we also look at the social determinants of health. And the social determinants of health, we put them into two buckets. We put them into one bucket, which is what is actionable by the patient as an individual, and then what is not actionable by the patient as an individual. As social workers, we look at the micro, the meso, and the macro level issues, right? And so we want the patient focused on those micro level issues where they can do something about it, while we as social workers work on the meso and macro level issues as well, and we may even get patients involved with that. And then we look at some other psychosocial factors as well. And then what our social workers do is they help us understand where the patient's readiness for change is, so that all of our clinical team is helping the patient to make changes where the patient is ready to make changes.
All right. So I have a question that I think some of our listeners might be thinking about too. And so when most people think of LCSW, they think of mental health, they think of substance abuse, possibly even like CPS type stuff. So how does an LCSW play a role in your clinic, and what you're doing with diabetes?
Yeah, I think for us, our clinical social workers are used to assess the mental health conditions of our patients. And so when we look at a patient, we look at the medical issues that the patient is, contending with, and their medical history. We also look at their mental health conditions, and we want to understand if any of those mental health conditions are being caused by the medical conditions, so we can, then intervene in one particular way. And then if it's not being caused by a mental health condition, there might be a different type of intervention, perhaps even outside of our clinic with other mental health workers that specialize in the issues the patient's facing. But we also take a look at the social determinants of health, and we separate those into the things that are actionable by the patient and the things that are not actionable by the patient, so we can help the patient decide whether or not they want to act in some of those areas. And then we look at some other psychosocial factors as well. And as importantly, we're evaluating readiness for change across the entire spectrum of things that we do: medical, mental health, social determinants of health, psychosocial. And we also do severity scoring inside of our clinic, so we can kind of look at the normalized severity of all of the things they're dealing with, and then help the patient make a plan for the one most next important thing.
That is phenomenal. I kind of, the way you guys have things set up, it's kind of like a integrated type system. I mean, you cover everything from health to mental health and everything in between. And I love that you guys are doing that, because physical health and mental health kind of play on each other. And
Yeah.
not a lot of people not necessarily understand that, but they don't really tie the two together. And you at Precina has absolutely done that. And I think that that's phenomenal. Um,
we
so
we want to make it actionable, right? Like, I think if people understand something but they don't know what to do next, and they don't know the one next thing to do, like telling someone to eat better and exercise, like that, I don't find that to be tremendously helpful. But if we say, like, we had one patient one time who was like, where do I start? And we said, well, what kind of coffee creamer do you use? And we looked at the coffee creamer and we said, well, let's look at a different coffee creamer. And we just changed their coffee creamer. And that coffee creamer made a little bit of a difference, enough for them to have confidence that we knew how to help them make small changes.
yeah, so it's that kind of the small win concept. You have a larger goal at hand, but you celebrate the small wins in between to
Yeah,
get to that larger goal.
you get it. Yeah, you
I
got
love
it.
that. So, and I don't know if you have these numbers or anything, study or through doing it this way, how many times have you seen anxiety being caused by the underlying disease, such as diabetes?
It's a great question. I don't have enough data yet to give you like a statistical number. We just received our first institutional review board approval to start publishing our data in a retrospective way like that. And so we're starting that research right now. I think um, my sense is it's not everybody that has kind of like clinical anxiety, but I think a lot of people have like subclinical anxiety about their condition, and there's lots of frustration we talk to people about. And so one of the things that we're starting to do is to kind of build that longitudinal data so we can track that for our patients and see where their anxiety is being reduced by certain interventions, and other interventions may not be as helpful inside of our practice, so that we can start publishing these protocols to people. We think that in the end, we're filling a gap that's not filled by primary care or specialist care. There's a new subspecialty of medicine that requires a different set of protocols, is my guess. I don't know that for a fact. I walked into this, in my doctoral program thinking that I was going to help with what was happening in primary care. But what we're doing, primary care physicians have shared with me they're just not set up to do the type of work that we're doing. And so we really support their work. We don't take over for them. We're not the quarterback. We're just the glue for them. They create the care plans. We help to titrate medicine. We help to make sure that the behavior change is happening. We really want to make sure it's happening sustainably for people. Of those 49 people that we helped get into control, 83% of them we kept in control for 2 years with no hospitalizations for any diabetes or diabetic related event.
Wow,
Yeah.
that's phenomenal. So, what is the typical percentage that you would see on that?
Yeah, I mean, I think that people will tell you that if someone has two chronic conditions, keeping them in control is, 10% of the time after 14 months. And if they have one chronic condition, 15% after 50% after 14 months, were some of the research that I saw. And there's lots of different studies that have, slightly varied numbers, but I'd say orders of magnitude that, that's directionally right.
Yeah, that's phenomenal. And I think we touched on this early on in the episode, and as you know, my brain goes all over the place. But
Yeah.
with with socioeconomic status, as I
Yeah.
told you offline, that's like my favorite. Sociology and the study of
Yeah.
groups of people is just phenomenal to me. But so socioeconomic status, it doesn't. Mental health and healthcare issues does not discriminate. So how
That's
does
right.
socioeconomic status play a role in what you're doing?
I think, when we think about socioeconomic status, that just is an umbrella of a whole bunch of individual variables that we want to check in with and then meet that individual precisely where they are. One of the great things about sociology is it does such an amazing job of looking at groups of people. But one of the dangers is that we don't go meet a patient exactly where that patient is. And one of the cautions that I give to our providers on a regular basis is you will be having success and doing great work with so many people all the time that it would be really easy for you to accidentally start one conversation with a patient that leaves off where you were with the last patient. Like we tend to do that sometimes.
Yeah,
If I've had a conversation 100 times, I might have that same conversation by rote memory versus connecting and meeting that patient where they are. And so I think from a sociology perspective, it tells us what variables to tune into. But my caution to our team is meet everybody where they are every day. Because if you met Chris yesterday, Chris might be in a different place today. And so just
yeah.
because he was in a great place yesterday, don't assume he's in a great place. Don't assume he's in a bad place either. Just make sure you're meeting them where they are. And hopefully we're helping move people forward. But it's true that people take a step backwards sometimes. And that's okay. And we want to make sure that's a shameless, like there's no shame in that. There's no guilt in that. Like we're all human. We all take backward steps. In fact, I'll share with you some of my own vulnerability. When I was going through all this, I was getting a doctorate, I was running a company full time. And while I was doing all of that, my A1C popped up to 7.
Oh, wow.
So here I am running a clinic, helping people with diabetes. And my doctor's like, hey, man, you've got diabetes and you're 60 pounds overweight. And I had to look in the mirror. It's like, wait a second. Am I not taking my own medicine?
Practice what you preach.
I had to. And I'm 60 pounds lighter today. My A1C is, around 5. And so, problem solved, but I'm a patient too now. And so I think it's always the running joke. I'm not just a founder. But But the reality is that I backslid. And so that was a real wake up call for me to have a lot of empathy and grace and humility about the process, and to encourage my team, like, hey, we all have to have that humility, empathy, and grace. And we all are where we are. And wherever we are, just go meet people right where they are. And so I think, I love, community health and public health statistics and the big numbers and moving system. I'm a social worker. I love systems thinking, right? Like
Yeah,
that's what we're
plays
trained in, of
hand in
course.
hand.
Absolutely. But we also have to make sure that we meet people right where they are and help that person take the one next step they need to take. And that's the expert plan you heard me talking about, matched up with
Yeah,
what the patient is ready to do. Because if I have an expert plan that a patient's not ready to do, that expert plan is worth nothing. Or
it's not going to work.
if I
Absolutely.
have a plan that's not an expert plan, it's like, hey, it's a patient plan that has no science behind it, where they have a plan, but it's the wrong plan. Well, that's not helpful either.
Yeah, it's almost
So
counterintuitive. So I love how you're saying meet the patient where they are, because that I think that's key in a lot of things. Mental health, substance abuse. I mean, with substance abuse alone, like not everyone's ready to be completely abstinent, and that kind of deters them from being clean. So harm reduction kind of meets them where they're at and allows them to gradually get to that end goal. And,
yeah,
and
I mean,
it,
look, marriage, friendships, parenting. Like I think to me, human relationships have been the thing that I've paid attention to the most closely for decades now. And so, and how people perform at high levels, and how relationships play into performance. And so, I think, I don't get sad about many things. The one thing I'm sad about in our society more broadly is that we're just not seeing the types of relationships we've seen historically from a sociological perspective. And so, like, there was
absolutely.
a study done longitudinally that, I don't know, 50, 60 years ago, I can't remember the exact date, but I'll give you again directionally the data. Men could talk to 12 other men in their life about anything from like a intimate friendship type of conversation. And when I reevaluated and looked at the data with a researcher in the early 2000s, let's call it 2006, 2007, that number dropped to less than two. And the Surgeon General has said that isolation is the greatest problem, health problem in our society today. And he's been saying that for a long time. And I agree with that. And so I think, you know, part of what we need to do as a medical practice is meet people where they are and have an appropriate clinical professional relationship. But we also talk to our patients about having the right non-professional care team around them, and how to
Yeah.
make sure they have a support system so that when they're not talking to one of the clinicians, when they're fully controlled and they're ready to be either discharged from the practice or, seeing us much less frequently, they have an environment that they can be successful in.
Yeah, they're able to continue on and still be successful. Absolutely.
Yeah.
Support system's huge in anything, whether it's mental health, healthcare, or just even friendship. Having a support system's huge.
Yeah.
And kind of while we're on the sociology side of things, I wanted to ask you, and it's just an opinion question. You don't have to throw facts
Sure.
behind it, but you can if you want. socio so social institutions play a huge role in the way we are brought up, the way we become adults.
Yeah.
How do you think social institutions play a role in these chronic diseases?
I mean, we do have some policy issues that have to be fixed right now, and there is no doubt that the food supply in the United States is different than the food supply in Europe. Like
Yeah,
that's just, and that there is science behind that. And
100%.
I think there's a lot of benefit to how we've changed the food supply from an amount of food that we have, so that hunger was the issue that we were solving. And so I think there's a lot of good reasons that we got to where we got to today. But I think we have to now reevaluate and say, okay, we are where we are, but like, what is this causing? And so I think that there are people that have anecdotal evidence about the food supply, and there's people that have science behind it. But I think an intellectually honest discourse around the topic is important for people, and understanding.
Yeah,
And by the way, I think there's people at the polar extremes of both sides of that conversation. My interest is in bringing people to the middle and having really good discourse around that, that's intellectually honest, and not involving character assassination, not involving tons of emotion to win a debate. Like, I don't think it's not a debate. I think this is about, understanding and deepening the understanding around like the social institution around food as an example. I think in medicine, there's a lot of bias in medicine. Some of it we understand really, really well in healthcare. Some of it we're just starting to understand. And I think we need to do a better job of leaning into cultural understandings particularly in small subcultures. We
Agreed.
bumped into a community of people in South Texas. It was a Hispanic community, and this Hispanic doctor was unbelievably kind and generous with me. And she said, I want to share with you some things about our culture that you may not be aware of. And I leaned in. I was like, tell me. I probably don't. And she said, there's a group of people down here that think insulin causes amputations.
You must be talking
I was
about
like,
the Rio Grande Valley.
I am. And
That's
and
where I
and
was born.
I said, well, why is that? And they said, well, because people come in, they're really, really sick, and they start taking insulin, and 90 days later have to have an amputation. And so in their mind, understandably,
They correlated to the insulin.
and it turns out that that's not limited to the Rio Grande Valley. I've bumped into other communities that have a similar belief system. And so, but if I didn't understand, some of what was going on in that community and what some of the influencers were experiencing in that community, like that would be a really short-sighted way for me to enter in. And so, I spent a lot of years living in New Mexico, and so I have a very, I'll call it a general awareness of some of the challenges with diabetes in Indian populations, native. Look at me,
Yes.
Native American populations. See, like I'll put my foot in my mouth all the time. So the Native American population, and so I was talking to someone recently about that. I said I recognize there's an issue. I don't know whether I'm the right person to help or not. I would like to be the right person to help. I know that we have medical answers and mental health answers that likely could be helpful, but I need someone to come in who is able to be a cultural guide for me because of how little I understand.
Yeah.
And so
No.
I think social institutions, we need to break down those walls, and people like me, and I'll just speak for myself, like I need to be willing to learn about where other people are coming from and about what their experiences were and recognize that mine are really different and not better, not worse, no judgment. But if I'm going to meet people where they are, then I've got to be willing to accept that they're in a different place than me with a different set of norms, a different set of, and I think when I talk about relationship with people professionally, I talk about acceptance being one of the most important things we do. Like we have to have acceptance, we have to have trustworthiness where we hold somebody's confidences, we have to have vulnerability. And then as important as any of those three things, we've got to have a willingness to see somebody in their best light without judgment. Like how can I see you in your best light, and whatever assumptions I could make, choose the best ones. And that's how we really form great relationships.
Yeah. No, I absolutely agree, and I think that social institutions play a huge role in shaping our perspectives through life, and sometimes
Mhm.
we don't challenge those perspectives and try to form our own. So I agree with you 100%, and I love the fact that you are meeting people where they're at, regardless of whether it's their health or just even their culture, and understanding their culture so you can better take care of them. I think that's phenomenal. I don't think a lot of people see it that way.
Well, I think in my mind, social institutions, sometimes they have an explicit agenda, and sometimes it's a subconscious agenda they may not even fully appreciate. And so, and again, I have no judgment about those agendas. I think I just, I'm interested to understand what's going on with that, right? Like I just want to understand what that agenda is. And then, I would say in most cases, I try to play with my cards kind of face up on the table. It doesn't work very well when I'm playing poker, so I don't do that then.
Yeah,
But
no kidding.
you
I
know,
want to play against
but
you when you're doing that.
yeah, but I will say that like when we're dealing with people and their health, and even in my friendships, I try to be, you know, as self-aware as I can be with the full recognition that I have blind spots, and there's weaknesses that I have that I know about, but I have to be honest about the fact that there's weaknesses I don't know about. And so it's given me a much more empathetic approach to other people if I can recognize my own weaknesses. Like, that whole like I don't want you looking at me that closely either type thing.
Don't analyze me, please. Yeah, no, I
I let
understand that. I think what you have going on is just absolutely awesome. And I know we're probably coming a little close to timing, but I want to see if you can break down, or if you can kind of just talk to us a little bit about Precina and what you guys are doing and what you guys
Sure.
are offering. I know that a lot of what we talked about has to do with that, but let's break down your clinic and the company you found and what you're doing with that.
Yeah. Yeah, we're a medical practice, and so we see patients by telemedicine only. We really broke down the entire medical practice as it existed when I was going through my research and built it back up to be effective. And we wanted to make sure that it was going to work really well for low income and rural populations that are underserved. And so we wanted to make sure that the clinical treatments worked, but also the economics worked for insurance companies. And so that's really how we built it, so that we can take on people in the kind of tougher situations. And we're really sensitive to the fact that patients can't just do what the doctor says. You've got to be really tied into that patient's life. And so we're excited about hopefully partnering up with some FQHCs in the future, and getting involved with national payers that want to bring us in and work with those populations that have been more expensive to serve. And so that's how we built the practice. And we're serving patients today in Texas and California, Oregon, and then we're moving out to all the 50 states. And so we're
Oh,
pretty
that is
excited about the work we're doing.
Yeah, absolutely. I think that is huge, especially the fact that you're helping, or you're trying to target the, and I don't want to use the word target because that seems kind of weird, but you're helping the people in the rural areas that can't find the help, or that have struggled to find the help. So I like that you guys are doing that.
We had to build something that would work for them, with them in mind. And once, the way that we built things up, it's like, if we can build things that work in low income and rural populations, it's easy to serve other populations once you've solved for that. And so, and that's
Yeah,
not to take away anything from the companies that kind of build for commercial payers or cash pay patients. I think those are all really important parts of our healthcare system too. We just saw this was a gap in a community that I've got a heart for. And so yeah.
100%.
Yeah.
Absolutely, I agree. And how can prospective patients or current patients find you? I mean, do you guys have a website? Obviously, what give us some information that our listeners can take home with them.
Yeah, I think you can just check us out at Precina.com. So Precina, Precina.com. And when you look at our website, you're going to realize we're specialists in healthcare. So I'd say,
I love
fill out the contact form, and we'll get back to someone will get back to you, and it'll be a really different experience. We don't, if somebody says, I don't want to fill out the paperwork for like my medical history, about, like, our physicians will actually do that for you while you're in the room with them on a screen like this, and they'll do that work for you. And crazy enough, like, we read a lot of the medical history before a patient comes in, so that we have that background, and it's just a little bit different experience.
Yeah, absolutely. I love it. And I think what you guys are doing is phenomenal. You, sir, are brilliant. And there's just so much to unpack with this episode. I would love to bring you on for a part two.
Yeah,
Um,
sure.
we can discuss a little bit, but I want to give the floor to you, and kind of, is there anything specific you want to let our listeners?
Yeah, I would just say, if you want to come geek out with us, just reach out to me. Like, my team will if you want to, connect with me on LinkedIn, Facebook, whatever, like, come find us and join the movement. Like, you don't have to have diabetes to join the movement. You can just join the movement, and just, come find Percina online somewhere. And, we're going to start putting out a lot of information about chronic disease, and trying to make it really accessible information for people who want to understand it, who aren't doctors, who aren't social workers. And so come check it out. We're gonna have a lot of information out there for you. And then if you want to engage in the conversation, like, I'm really approachable. Come find me. Like, I'll make time on my calendar. I love geeking out about this stuff. I shared with the world this was happening on social media recently. I had some old friends reach out and say, I didn't know you were working on this stuff, and they were shocked at how quickly I called them back just to catch up and connect, because I love talking about this. So yeah, just reach out. I'd love to connect with you.
Yeah, absolutely. And for our listeners, just keep an eye out for next week's newsletter. We have a little special tidbit from Dr. John, so hope you guys enjoy that. Um, as always, this episode will be airing at Friday, and thank you for joining us, guys. We'll see
Thanks
you
so
next
much. Really
week.
appreciate you having me. Take care.